Hello, in this video I want to discuss the similarities and differences in clinical features between lower motor neurone and upper motor neurone lesions. But I think the first thing that we should do really is just remind ourselves of the basic distinction between these two populations of neurons in the motor system. So the first thing we'll do is just draw the motor system as a chain of two neurons. So here is the cell body of the upper motor neuron. And you should recall that the cell bodies of upper motor neurons are present within the motor cortex, which I can abbreviate as M1 for the primary motor cortex. They send their axons down through the brainstem and spinal cord, primarily within the corticospinal tract, and then they synapse upon the cell bodies of lower motor neurons. And you should recall that the cell bodies of lower motor neurons are generally found within the ventral horn or various motor nuclei of cranial nerves within the brainstem. So I'll just put ventral horn here. And then remember that the axons of lower motor neurons project out through various peripheral nerves to synapse ultimately on muscles. Okay? So that's the basic chain of two neurons within our motor system. And we're going to refer to this again and again when we're trying to explain why we get these various clinical features. So let's go through these clinical features and just make sure that we are happy with what they mean. Power. When you're assessing power clinically, you essentially ask the patient to do various movements which you resist, and in resisting that movement you can make an assessment of the strength that they have in their limbs. So power is probably the simplest of these features to understand. Muscle tone refers to, if you like, the background level of muscle activity. And what you ask a patient to do is ask them to relax, and then you passively move their various joints. And in a normal patient, you will find that the joints move quite freely, so the tone is relatively low. We ask about the presence of rigidity or flaccidity, okay? So rigidity is essentially a manifestation of increased muscle tone. So if you try to move some muscles which are rigid, you will experience resistance, whilst flaccidity is a feature of decreased muscle tone. Reflexes, so the familiar reflexes like the knee-jerk reflex or the biceps reflex. Reflexes can either be normal, diminished or absent, or increased. The presence of fasciculations and fibrillations. Okay, fasciculations are macroscopic, so visible by the naked eye, whilst fibrillations are an electrophysiological phenomenon. And I'm going to be focusing on fasciculations here. And these are essentially involuntary muscle contractions, but uncoordinated muscle contractions. So the muscle fibers are contracting at different times, not all together. And finally, atrophy is where a muscle shrinks, and that can either be down to loss of neuronal input or down to lack of use. And just like, thinking about astronauts who go into space have to exercise to maintain their muscle mass, if you're paralyzed and you don't use your muscles, you can become atrophied through a similar mechanism. So let's go through these features and just make some general comments. So the first thing we're going to look at is power at the top of the list here. And in both upper and lower motor neuron lesions, we experience a diminution in the muscle power within the affected regions. And that stands to reason, doesn't it? Going to our very simple model of a chain of two neurons, we know that in order to move the muscle, we need an intact lower motor neuron with an intact axon synapsing upon the muscle. And if there is damage to this, then we will get decreased power because we just can't send signals to the muscle itself. Furthermore, if we have damage to upper motor neurons, we do lose some of the excitatory inputs onto the lower motor neuron from the upper motor neuron itself. And I just want to put a little plus there just to illustrate to us that the upper motor neuron does have an excitatory influence on lower motor neurons, but as we'll discover later, this is not the predominant influence that these neurons have. So power is relatively straightforward to understand, so these patients, regardless of whether it's upper or lower motor neuron, have weakness. Next, going on to muscle tone. Remember, we said that muscle tone is this background level of contraction. In lower motor neuron lesions, we see that there is a decrease in muscle tone. And we can explain that using the same kind of principle that we use to explain the loss of power. That is, that if the lower motor neuron has become disconnected from the muscle, we've lost that background level of neuronal activation, so therefore the muscle tone will drop. However, tone in upper motor neuron lesions is a little more complex to understand. Interestingly, in upper motor neuron lesions, initially, so I'm thinking hours to a couple of days after the lesion, initially tone is decreased, just like in lower motor neuron lesions. However, after some time, so after a few days to weeks, tone actually starts to go up. We become hypertonic. And it is in fact this increase in muscle tone in upper motor neuron lesions that causes a lot of the problems associated with these conditions. So how does this increase in tone occur? Well, I discussed this in other places. However, it's well worth just reminding ourselves of the basic idea. We said earlier that the upper motor neuron is excitatory onto the lower motor neuron, and that is true. It has to be true because this is the mechanism whereby we get voluntary movement. However, it is interesting to note that these excitatory influences from the upper motor neurons are numerically in a minority. And in fact, the majority of influences coming down the corticospinal tract and synapsing onto the lower motor neurons are in fact inhibitory. Okay, so most of the influences impinging upon the lower motor neuron from upper motor neurons are inhibitory. And this is a very important concept to understand. What it tells us is that normally the lower motor neuron is held in a state of relative inhibition. If you wish to move voluntarily, you send strong trains of action potentials through these excitatory pathways and you activate the lower motor neuron. However, during normal resting behaviour, the net effect of the upper motor neurons on the lower motor neurons is one of inhibition. Now we've got to add one other thing on as well to understand how this increase in tone arises. And that is we need to add the sensory side of the spinal reflex arc. So remember that we have muscle spindles which are detecting muscle stretch. They are connected to first order sensory neurons which then synapse on lower motor neurons at excitatory synapses. Now, if you damage or destroy the corticospinal pathways or damage the upper motor neurons, what you have done is you have deprived the lower motor neuron of its inhibition, and you have taken the brakes off of the lower motor neuron. And what is still present, however, are these excitatory inputs coming from the afferent sensory neurons. So the monosynaptic reflex arc is still active. There is still excitation coming from the muscle spindles, but we've lost this element of inhibition. And so what we see is that the activity of the lower motor neuron increases. It increases, and this is what leads to our increased muscle tone. However, how do we explain this initial decrease in the amount of muscle tone in the immediate period following an upper motor neuron lesion? Well, we explain that through the phenomenon of spinal shock. And essentially, spinal shock remains a relatively poorly understood mechanism. But the way I think about it is that if we acutely deprive the lower motor neuron of a large number of its inputs, it actually kind of becomes a little lonely, a little depressed, if you like, and drops its activity level. By dropping its activity level, it actually sends fewer impulses to its muscles, and the amount of muscle tone drops. However, as the period of spinal shock starts to wear off and the intrinsic activity of this lower motor neuron begins to increase, it becomes more and more responsive to inputs from muscle spindles, and because it no longer has the descending inhibition, its activity increases even further, so that this monosynaptic reflex arc goes into overdrive, and that's what causes our increased muscle tone. Now, related to muscle tone is the concept of rigidity or flaccidity. And this is essentially the same as the tone discussion that we've just had. In the case of lower motor neuron lesions, we have a persistent flaccid paralysis. Okay? So damage to lower motor neurons leads to a persistent flaccid paralysis for the same reasons as when we discussed decreased tone. Whilst in upper motor neuron lesions, we have an initial flaccid paralysis, which then turns into a more rigid paralysis. And in fact, that rigidity has an alternative name, which is spasticity. Okay, so spasticity is simply a synonym really for this rigid paralysis that we see in upper motor neuron lesions. What about reflexes? Well, as you can see, in the case of if we ignore all of this to do with upper motor neurons, if we interrupt the axon of a lower motor neuron, we interrupt the monosynaptic reflex arc. And so therefore, in this case, the reflexes become diminished. Okay, the reflexes become diminished in the case of a lower motor neuron lesion, and they may even become absent if the damage is extensive enough. Remember, though, that in the case of an upper motor neuron lesion, our lower motor neurons have become intrinsically more active, all right? And so therefore, what we ultimately see down the line is that in upper motor neuron lesions, the reflexes increase. There is hyperreflexia. However, due to the period of spinal shock, initially there is actually a diminution in the reflexes, which then turns into hyperreflexia for just the same reasons that we discussed earlier. What about this thing, fasciculations? Now, fasciculations and fibrillations are specifically a lower motor neuron lesion phenomenon. So this does not apply to upper motor neuron lesions. We'll focus on fasciculations. Basically, if you think about what's going on, when the lower motor neuron is intact, the motor end plates are there at the synapses, at the neuromuscular junctions, and the acetylcholine receptors on the muscle fibre are localized to the neuromuscular junction. However, if we damage or destroy the lower motor neuron, then what we actually have is less of an incentive for the muscle fibre to maintain its acetylcholine receptors just at the synapses. And in fact, the muscle fibre starts to upregulate its expression of acetylcholine receptors so that they become expressed more widespread over the muscle fibre itself. And if you have lots and lots of acetylcholine receptors widespread on your muscle fibres, the muscle fibre becomes responsive to circulating levels of acetylcholine, and this can cause involuntary contractions. So that is fasciculation, all right? And fasciculation is present within lower motor neuron lesions as well as fibrillations. I'm not going to talk about the physiological mechanism of fibrillation, but just be aware that it exists as a neurophysiological feature of lower motor neuron lesions. Finally, let's consider atrophy, which is where the muscles which are supplied may decrease in size. And this can be caused by a number of mechanisms. In the case of a lower motor neuron lesion, we get atrophy, we get marked atrophy, because normally the lower motor neuron delivers a whole load of growth factors and other substances to the muscle fibre along its axon. If you interrupt the axon of a lower motor neuron or destroy its cell body, you lose this supply of growth factors and other goodies, and therefore the muscle fibre is receiving less of a growth incentive, if you like, and will tend to atrophy. Okay, so atrophy is a pronounced feature of lower motor neuron lesions. Upper motor neuron lesions also demonstrate atrophy, but to a much smaller extent. So I'll just put a small tick in there. So atrophy is a feature of upper motor neuron lesions, but due to a different mechanism. In the case of upper motor neuron lesions, the lower motor neurons are still present and they are still able to deliver growth factors to muscle fibers. However, just due to the fact that we have a paralysis, that the lower motor neuron is not being instructed to do stuff voluntarily by the upper motor neuron, we get a so-called disuse atrophy. A disuse atrophy where just because the patient is not exercising that muscle due to lack of voluntary movement, the muscle will get smaller. But it is nowhere near as pronounced as the atrophy seen in lower motor neuron lesions. So I hope that was helpful. A very brief summary on the similarities and differences between upper and lower motor neuron lesions. Thanks for listening.